Good afternoon, everyone. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland. And welcome to this, the 9th QI Connect session for 2018, the 48th since the series began. QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, innovation and integration. So welcome to QI Connect. I'm going to pass you over to Jennifer, who's going to tell you a little bit more about the technology we'll be using on QI Connect today. Good afternoon, Jennifer.
Good afternoon, Brian, and good afternoon to all of our QI Connectors joining us today. So I just have a couple of quick housekeeping slides to get started on the WebEx. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be an interactive learning experience, and we do encourage you to use the chat function to share any questions, comments or ideas throughout the talk. And there will be an opportunity for Q&A at the end of the session. We will also be sharing hyperlinks within the chat function to any resources mentioned by our speakers today. So we did promise that today's session was going to be fun and interactive, so this is the interactive part. So we're keen to find out where you're joining us from today. If you could please select the annotation tool that you see circled in red here, top left-hand side of your screen, and then click on the arrow icon, again circled in red, and then if you could just click on the country that you're joining us from today. This is where we see the UK disappear under a cloud of names.
And we see our colleagues from Canada joining us from, I think, 5 provinces this afternoon. Jennifer?
Brilliant. Hi to everyone. We'll just give everyone just a moment to know that people joining from overseas, sometimes the connection, it just takes a couple of seconds to work.
Great. Well, welcome everyone.
Great.
It's great to see you all joining us. Welcome to QI Connect. We're absolutely delighted with the reach of QI Connect, and I can announce today that we've broken through the 1,000 barriers. We have more than 1,000 organisations that have signed up for QI Connect over the last 5 years. We're absolutely delighted with that. And remember, you regular QI Connectors, that we have a competition. So every episode we have a competition, and we name one of the countries that's joining us today. And if you get your finger on the arrow again, I'm going to name the country, and the country today is India. Okay, and the arrows are just a bit slow today.
Yep.
Oh, there we go. Nearly close, Andrew, but no cigar. Andrew, great. Well done. We have Andrew Carnan, a consultant in public health from NHS Dumfries and Galloway. So well done, Andrew. And you won the prize for today, the country of India, and you receive a QI Connect mug, a much sought after QI Connect mug. So well done, Andrew, absolutely super. And just to give a big shout out to some of the new organisations that are joining us today, ranging from the Healthcare PVT, the HRI in India, you're very welcome to join us, and our colleagues from Ontario, from London, from Tainult, just down the road here in Scotland, and Edsel, just down the road here in Scotland as well. You're all very welcome to QI Connect. And we're always delighted to shout out to all of the NHS organisations in Scotland who regularly join QI Connect. You're very welcome. And a wonderful, we've now reached It's a wonderful figure of 76 universities who now dial in regularly to QI Connect and use our resources. And a shout out to the University of East Anglia, who are joining us for the very first time today. Remember, all the QI Connect webinars are recorded to be downloaded and used at your leisure. We know that many of the universities and colleges, and indeed many of the organisations, use the recordings to learn together after the event itself. A big shout out to the International Society for Quality in Healthcare, whose fellowship programme use the QI Connect resources regularly as part of their curriculum in their fellowship programme. And again, a big shout out to our friends at the Health Foundation, the Q Initiative and NHS Improvement. It's been a great partnership to further extend QI Connect's reach and use through the Q Initiative here in the United Kingdom. You're all very welcome. And just a shout out to the small but perfectly formed QI Connect team. You've heard from Jennifer earlier in the call. We're joined in the studio today by Michelle, who's on registration. Jess is next door, who helps with registration and running the show. And we have Carmen, who deals with all of the administration and certification. And Alex Sterling, who's on a well-earned break this month, supports us in Twitter. So that's the team that brings QI Connect to you wherever you are across the globe. And we will be joined later in the episode today by Laura McIver, our Chief Pharmacist here at Healthcare Improvement Scotland. We're looking forward to hearing from Laura later in the call. Remember to use Twitter. We're on #QIConnect or follow us at HISQIConnect. Please spread the word and share the resources using Twitter. You're very welcome to do that. And that brings us on to today's episode of QI Connect. Our QI Connect speaker today graduated in medicine at Cambridge University in 1985 and trained as a hospital physician in London. She undertook a Harkness Fellowship at Harvard in 1994, where she explored the area of bridging the gap between medical research and practice, a question that continues to challenge us internationally today. She's a highly visible leader in the fields of transparency in academia and academic publications, publication ethics, climate change, quality improvement, harms in medicine, the list goes on and on. Dr. Fiona Godlee is the first female editor of the British Medical Journal in its 180-year history, taking up the position of Editor-in-Chief in 2005. And today, Fiona joins us from the World Health Organization in Geneva. Good afternoon, Fiona.
Good afternoon, Brian, and hello, everyone.
And you're very welcome to QI Connect, Fiona. I've just passed the ball to you, and we're very much looking forward to your talk.
Thank you very much indeed. Well, thanks for joining, everyone. I am speaking from Geneva. I've been attending and taking part in a conference on air pollution and health, and at the end I'll ask you to identify the moment in which that becomes relevant to the conversation that I'm about to embark upon. So I'm going to be talking about too much medicine, turning back the tide of medical excess, which isn't entirely unexpected as a topic in terms of quality improvement. And I just wanted to start off with a picture of my mother, who is someone who disliked doctors as a breed and avoided them as far as possible. And it was rather perverse in that sense that she married one and that all 4 of her children became doctors. And here are 3 of us with my dad, and that's me at the bottom of the picture being thoroughly trampled on by my other siblings. I say this because I think it's important to make, as my starting position, make it clear that I believe in medicine, and I think it's a good thing. And it does amazing, wonderful things, and modern medicine is one of humanity's great achievements, prolonging life and alleviating suffering. So even if my mother didn't like doctors, I certainly do. But here is my thesis, that medicine has great potential to do harm, and it has got things wrong in the past. In fact, in some cases, terribly wrong. We all know the history of bloodletting and the damage that did over the years, and continues to do wrong. And this is just one example, a book by Vinay Prasad and others, which looks at the question of medical reversals. This is where medicine adopts ineffective or harmful medical practices only to abandon them sometimes too late. And Vinay Prasad subtitled his book, Why 40% of What We Do is Wrong. I think the message here is that we have to be humble in our approach to medicine. And there is a real sense that medicine has become commercialized and marketized and has taken over from religion as the thing we turn to deny our mortality. And we've allowed it to encroach into areas of our lives where it doesn't really belong, where it brings, in some instances, minimal benefit and definite harm, turning people into patients and placing huge unwarranted costs on health systems and therefore on society. And so I think it is our responsibility to be aware of this and to begin to turn back this tide of medical excess. So life expectancy increases have been something we've been used to over the years, but these increases are stalling in many developed countries, as this slide seeks to demonstrate. And this was confirmed in this recent paper, just at the bottom of that slide, Recent Trends in Life Expectancy Across High-Income Countries, where they found that that there was really a stalling in the UK as well. And lots of thoughts on why this might be true. Is this due to austerity? Is it due to the opioid epidemic? But the other point here is that costs of healthcare continue to rise. And this slide, I hope, demonstrates the idea that as life expectancy at birth is stalling, the health expenditure per capita is exorbitant in those countries that are still spending a vast amount, but not getting that benefit in terms of increased life expectancy. So in the 20 years from 1995 to 2014, Sierra Leone, I can't picture where it is on this slide, it showed increased spending of about $150 per head and gained 15 years in average life expectancy. But the USA, which is at the top right of this slide, increased spending by about $7,000 per head. And I should say this is a log scale, so it doesn't quite show the extent of that. And they gained for that $7,000 per head only 4 years. And as I said, those gains are now stalling. So most deaths globally are now caused by non-communicable diseases. 2/3 of deaths worldwide, according to the Lancet Global Burden of Disease. And these non-communicable diseases are largely what are called lifestyle diseases: diabetes, heart and lung disease, cancer, mental disorders. And a large part of the increasing cost of healthcare is due to the drugs prescribed to prevent or treat the effects of these diseases. So I think we need to begin to question that explosion in the number of pills we're taking. And these data come from prescription data in the UK, which show that 1.1 billion prescription items were dispensed in 2016, which is an increase of 47% in the past decade. And nearly half of adults are now taking at least one prescription drug, a quarter of adults taking at least 3 drugs, and nearly half of over 75s taking at least 5 drugs. And this is something that is seen in other places too. Here is data from Australia showing a 72% decrease in annual prescriptions over the past, that period of a 10-year period. Chris Santallican, who some of you will know, is a very excellent television doctor in the UK, and he has called this a tsunami of drugs designed to prolong life. He makes the point that most encounters with doctors end up with a prescription, and in the course of a lifetime, a healthy person takes an estimated 100,000 pills. And in this program, some of you may have seen, he said, it's important to say that some of these drugs do good, but they can all do harm. And these harms include causing about a quarter of hospital admissions for the elderly due to adverse effects of prescription drugs. And the Food and Drug Administration in the States in 2014 estimated that about 123,000 deaths that year were due to adverse effects of prescribed medicines, which had tripled in a decade. And this was before the opioid epidemic that is we could say is largely partly due to overprescribing. The main drugs involved in the NHS increase in prescription are antihypertensives and statins, as these data show. And these drugs are increasingly prescribed to people who are considered at low risk of heart disease, where the benefits are marginal or non-existent, and they're benefits that are far less than patients might expect from taking a drug every day for the rest of their lives, and with the potential harms of taking those medicines. So, whereas with high-risk people, obviously the benefits and risks are much more balanced, but when we're talking about people at low risk, we're talking about really perhaps not many people, if they were explained those risks in more detail, would perhaps be less willing to undertake the drug treatment. Statins are the most let me just explain this slide. Yes, this is really just to look at that point about, as I'm sure many of you will know about this, but as risk diminishes as you move to the right-hand side of this graph, the benefits tail off, but the side effect profile in terms of accumulative incidence continues to rise. So at some point in the high-risk, low-risk spectrum, there's a point at which the crossover and the side effects outweigh the benefits that are provided. Statins are now the most widely prescribed class of drug worldwide, and the evidence suggests that they provide really no survival benefit, and this is an article in the BMJ that presented those data, provide no survival benefit in people aged over 75 who are at low risk of cardiovascular disease. This is an observational study, but it's in line with studies that have reanalyzed available randomized trial data. And you may know that we've been trying to push for, oh, sorry, I've gone too far ahead, let me say, that we've been trying to push for access to the data to allow for independent researchers to get the trial data so they can actually analyze them. The trials didn't include the elderly, and as often is the case, the harms of statins have not had the same level of scrutiny as the benefits. So there's a real imbalance there, again, about this harms and benefits balance. Just out of interest, there is another tsunami, picking up that Chris Van Tulleken idea, another tsunami of drugs on the way being indicated to treat non-alcoholic fatty liver disease. So that's at the bottom of this slide. It's already estimated to affect more than a quarter of adults, and up to 90% of people with obesity or type 2 diabetes are thought to have non-alcoholic fatty liver disease. And as with obesity and diabetes, this condition can be reversed with weight loss and exercise, but I gathered the other day that there are nearly 100 new drugs currently in development for this condition. So it's a terrific boon for the pharmaceutical industry, but all of these drugs will have side effects, and the market is estimated to be $1.6 billion by 2020 in drug treatments for non-alcoholic fatty liver disease. So this seems to me to be an appalling prospect where we have a largely lifestyle disease with drugs about to be launched onto the market in large numbers. And meanwhile, the market for drug treatments is getting bigger all the time as the risk factors are presented as diseases in their own right. So we've got pre-diabetes, pre-dementia, and pre-osteoporosis. Sorry, this slide hasn't come out quite right, but behind this are just some signs that this idea of preconditions. The term pre-hypertension was coined in 2003 for people with normal blood pressure, but in the higher range of normal. And 1 in 3 adults was said to be pre-hypertensive and therefore at risk. And this idea of being at risk of being at risk is something that Ray Moynihan has talked about. People increasingly are at risk of being at risk of disease. The committee that decided on this new category of pre-hypertension back in 2003, Ray Moynihan, a journalist in Australia, found that 11 out of 12 of those committee members had ties to industry. So the definitions themselves for these pre-diseases are heavily influenced, one might argue, by industry interests. Recently we've had the new American ACC, American, I'm going to say Committee of Cardiology, anyway, and then we've got the American Heart Association, combined American College of Cardiology and the American Heart Association, this high blood pressure guidelines. And they have redefined elevated blood pressure as 130/80, which is going to be more than half of adults aged over 45 will be labelled now as hypertensive. that's an extraordinary figure. That's 1 in 2 adults are going to have this label of actually hypertensive. At the Preventing Overdiagnosis conference in Copenhagen earlier this year, when these this idea was considered, there was a rather dark humoured conversation about at what point will it be 1 in 1? What point will there be diseases that affect 1 in every adult idea? And I suppose we came to the view that death is the answer, that we are all going to die and there's no escape. So that's already happened. But 1 in 2 adults, a huge number. Studies published in the BMJ in response to this new definition of hypertension found that this equates to 70 million people in the US, 267 million people in China being eligible for antihypertensive drugs, 7.5 million people in the US and 55 million in China would be newly recommended to start treatment, while 14 million in the US and 30 million in China would be advised to receive more intensive treatment. So this is an example of what might be considered to be disease mongering. Pulling more people into the diagnostic net, turning people into patients, and so not only a pill for every ill, but now an ill for every pill. So we have these pre-hypertension, pre-osteoporosis, pre-diabetes, new types of diseases that, or new names for risk factors becoming diseases. To hammer home this point, a few years ago, we published in the BMJ a news piece, and it was published on April the 1st in 2006, so we thought it was a pretty good sign that it was a spoof. But it was a news item which suggested that scientists had found a new disease called motivational deficiency disorder, which was so common it was considered to affect 1 in 5 Australians. And it was a very severe condition which removed the motivation to breathe in some cases. But luckily for the sufferers of this disease, a new drug had been invented called Indolabant, which was so effective that sufferers had been transformed from being confined to their sofas to becoming investment bankers in Sydney. We thought this was a pretty clear spoof, but a newspaper in New Zealand picked it up and put a big front page story saying new condition, new drug for new condition. And the editors of the newspaper were extremely angry when they discovered that they had fallen for this spoof. But some of our readers understood the joke, and we got one rather marvellous rapid response letter to the editor which said, "We discovered this condition 5 years ago but couldn't be bothered to write it up." So humour can play a part in trying to make clear the issues that we're dealing with. So I talked a bit about the pills and the tsunami of pills and the problems and the harms and the evidence base and all of those things. It's obviously a bit of a rush through, but I just wanted to move on now to the idea of the problem of early detection. What about early detection to prevent and treat disease? It sounds like a good idea, but is it in all cases? And the problem we have is that new technologies are able to detect smaller and smaller abnormalities, and it's not clear in many cases what to do with them once you've found them. So we've run a series of articles, and this is just to highlight one on CT pulmonary angiograms looking for pulmonary emboli. And many of these emboli don't need to be found. And this is data which shows that point, which really indicates that as detection rates have increased, that's the green line, the incidence and diagnosis of pulmonary emboli. The mortality, that's the bottom dotted green line, really hasn't shifted over the years. So we're really getting a case of more diagnosis with really no sign of benefit. And this same picture can be seen in other conditions. So here we have thyroid cancer. And again, with all these new technologies, which are the vertical dotted lines, widespread use of thyroid ultrasound, and we've got fine needle aspiration, increase in CT and MRI, and then ultrasound-guided aspiration. So the green line of incidence rising very rapidly during this period, but the dotted line, the red line, showing no shift in mortality. And again, that seems to be pathognomonic of overdiagnosis. And again, here we have it, the same picture for screening mammography and the incidence of invasive breast cancer. Again, new technologies finding more breast cancers, but the mortality from metastatic breast cancer staying very stubbornly unchanged. Cancer overdiagnosis is the detection of asymptomatic cancers, often through screening efforts, which are either non-growing or so slow-growing that they never would have caused medical problems for the patient in the patient's lifespan. And this slide aims to show that, where you've got these different types of cancer, some of which are fast-growing, obviously you want to detect those, some of which are much slower or indeed non-progressive. And screening detects really all of these, and it's those very slow and non-progressive cancers which might resolve spontaneously without treatment, which represent an important cause for over-treatment, can involve serious harm and toxicity such as deaths from surgery, major organ deformation or loss, and second cancers from radiation or chemotherapy. So that's really one of the things we need to think about overdiagnosis, is that it may seem like a victimless crime, if you like, but in fact there are harms as a result of the excessive treatment that follows. Just to put that in context, in the prostate early detection, the harms of early detection, I hope, can be seen quite clearly on this slide. So you've got two groups of men represented here, 1,000 men who didn't have early detection, PSA, screening, etc., and then 1,000 men who did have that early detection. And the same number of men in both groups died of prostate cancer, and all cause, that's the red, died from prostate cancer and died from any cause. But in the screened group, that's the side on the right, 160 men had unnecessary prostate biopsies, that's the pale blue, and 20 had unnecessary treatment for prostate cancer with all of that entails, that's the dark blue. So really, those with early detection ended up overall having a less good experience and sometimes being quite badly harmed as a result. So too much medicine really comes from a combination of overdiagnosis and overtreatment, and these two things are clearly linked, as I've just hopefully described with the prostate example. And overdiagnosis is defined as the diagnosis of disease that will never cause symptoms or death during the patient's lifetime. It's a side effect of testing for early forms of disease, which may turn people into patients unnecessarily and may lead to treatments that do no good and perhaps do harm. I think very important, because to ignore this would be quite wrong. It's very important to stress that overtreatment and overdiagnosis can coexist and does coexist with underdiagnosis and undertreatment. And you all know that there are many people experiencing too little medicine through lack of availability or lack of access or knowledge, and there are huge variations in care, both globally and also locally, even within countries, even within cities, due to things like socioeconomic variation, access to different types of treatment. But it's also important to notice that overtreatment and undertreatment are linked in another way, which is because overtreatment drives up healthcare costs and diverts resources away from those who need it, then that is an opportunity cost. And for example, an estimated 20% of US healthcare is considered to be unnecessary. Don Berwick and others published these in JAMA in 2012. And it's that unnecessary healthcare which diverts effort and cost away from the people who need treatment. Margaret McCartney, who many of you who read the BMJ will have seen as a very, very important commentator on this issue, puts it very succinctly in her book, The Patient Paradox, where she says, too much testing of well people and not enough care for the sick worsens health inequalities and drains professionalism, harming both those who need treatment and those who don't. So what are the drivers of too much medicine, medical excess? This article in the BMJ back in 2014 listed quite a few. It included increasingly sensitive tests, and I talked about that, tests that find things that didn't need finding, expanded definitions of disease and lowering of disease thresholds, again I've talked about that, the creation of pseudo-diseases, disease-mongering, I gave some examples of that. In addition, this article talks about clinicians' fear of missing a diagnosis or of litigation, incentives to do more tests. The government may, for example, set incentives. Public enthusiasm for screening. It seems like an obvious win-win, doesn't it? Detected early, we don't want to have that removed. Once it's been offered to us, we'll feel deprived and discriminated against. So there is a public enthusiasm for that. And policymakers and commercial enthusiasm for screening and prevention for their own reasons might want to push it. Patients may desire testing for reassurance. And of course, then there are financial incentives to doctors, amongst other people, to actually push for further tests and treatments. in the UK, we have the Quality and Outcomes Framework, which pays doctors for doing tests, blood pressure tests, and for prescribing certain treatments. So there are a number of drivers, and it's a very complex multi-system problem that we're up against. I wanted to mention also the driver that is, let me first of all give this quote from Fiona Godlee because it's so good. She talks about a toxic combination of vested interests and good intentions, because I think that really describes the fact that there are people here doing important good things. They're all trying their best. It's not that people are being malicious or evil. It's just that they're caught up in a system which makes it very difficult for people to see the wood from the trees. I wanted also, though, to concentrate on the science behind the medical guidelines, the medical decisions we all make, and to talk about how that too contributes to overdiagnosis and overtreatment. Because it turns out that we have a systematic tendency in the research evidence to overstate the benefits and understate the harms of interventions. And this was an overview published in 2010 in Trials, which looked at reporting bias in medical research. And these authors from the German Institute of Quality and Efficiency in Healthcare found that reporting bias or publication bias represents a major problem in the assessment of healthcare interventions. They identified reporting bias in 40 indications comprising around 50 different pharmacological, surgical, diagnostic or preventive interventions. Many cases they found involved the withholding of study data by manufacturers and regulatory agencies, or the active attempt by manufacturers to suppress publication. And the effect of this reporting bias included, in their view, the overestimation of efficacy and the underestimation of risks of interventions. So that contributes to this idea that treatments are better than they might, that they really are. And you might call it a form of optimism bias, where we as humans, we like to feel that things are going to be better. The new drug are better than the old, any drug better than no drug. And that really does seem to be a systematic tendency of the medical literature. And this was just to remind me to say that we know that positive studies, those that find the new drug better than the old or any drug better than no drug or treatment, are more likely to be published faster, published in higher impact journals, more likely to be cited, and often indeed published more than once, which is one form of sort of boosting up the way in which the research presents the data. And this seems to me to be an important example of that. This is a study looking into the drug reboxetine. Again, this comes from Germany, this work, and Germany has a group called IQWiG, which is, in my view, a rather more muscular version of the National Institute for Clinical Excellence in the UK, where they decide on the evidence base for treatments that will be provided through social insurance in Germany. And they were wondering about whether they should provide reboxetine through the National Social Insurance Program. Reboxetine is an antipsychotic, antidepressant drug, and they were sort of aware that they didn't have all the data on this drug. So they asked the manufacturer, Pfizer, to provide the data. And Pfizer, first of all, said no, they wouldn't. And IQWiG said, well, if you don't give us the data, we won't let your drug be made available through our schemes. And so Pfizer eventually did deliver up all the data, and it turned out that about three-quarters of the data had never been published. And when the IQWiG researchers put the published data alongside the unpublished data, they found a very interesting picture. So let me talk you through this slide. You've got 4 outcomes. You've got remission, response, patients with adverse events, and withdrawal. I'm just going to talk about the first 2 and the last of these. So if you look at remission, and you look at the top blue button on this forest plot, you'll find that it shows that there is a benefit, overall benefit of the drug from the published literature. So that's that top blue dot. If you look at the unpublished literature, on the other hand, it brings the dot right against the no difference between the active and placebo treatments, and therefore, if you sorry, I'm just receiving. If you look at the total combined published and unpublished literature, you get a result that is no difference between the active and the placebo treatments. Likewise with the response rate, the published data shows a good effect, the unpublished no effect, and the 2 together no effect. If you go to the bottom 3 blue dots, the published literature there shows no difference in terms of side effects between the active and the inactive treatment. But if you look at the unpublished data, you get a very different picture with a very much worse side effect profile from the active drug. And published and unpublished together shows that the active drug has a much worse side effect profile than the placebo. So here you have a drug which was originally considered to be effective and safe when you look at the entire data set, ineffective and harmful. I think that's a very important result, and it's a result that we find repeated when all the data are found again and again, this over-optimistic view of drug treatment. The literature also has a tendency to exaggerate sorry, let me just reframe that. There's quite a lot of bad science published in medical journals, I'm afraid, and I can't pretend the BMJ escapes that always. And this is a really interesting study published in the BMJ, which shows that as the science gets worse, the effect size, showing a positive effect size, increases. So these authors looked for discrepancies within trials. And as you move to the right of the slide, you'll find that the number of discrepancies in the trials increases. So those 5 trials on the far right had more than 30 discrepancies. And those 5 trials had reported a much bigger effect size in terms of this particular intervention, stem cell for autologous bone marrow stem cell trials. So this seems to indicate that poor science, of which there's a great deal, it tends to push a more positive view of interventions, and therefore encourage this idea of too much medicine. So I hope this kind of romp through quite a broad number of topics shows that we have a problem. And this slide is really to remind me to say that we all agree that we need to use evidence to guide clinical and policy decisions. But there's an assumption that evidence is like a commodity that is all of the same quality, like water, available on tap whenever we need it. But in reality, this is far from the case. There is water, and there is contaminated water, and it really matters which one you drink. And it's not always easy to tell the difference. And that goes for evidence as well. So what can we do about this? There's a paper here by authors published in the BMJ in 2017 which looks at a range of solutions, and this is a complicated slide, but I'll just quickly summarize it. They talk about the need for cultural change to encourage healthy skepticism about early diagnosis. They talk about health system change to reform incentives from quantity of treatment to quality of treatment. They talk about industry and technology. We need to better evaluate disease definitions as one thing we need there. And then professional change to encourage greater comfort with uncertainty so that doctors and other professionals are willing to talk about the uncertainties around treatment. And then patients and the public. We could promote more the idea that it's maybe all right to do nothing, and to get patients and the public to ask that question. What about if I did nothing? What would be the outcome if I decided to walk away from chemotherapy? If I decided to walk away from cardiovascular preventive drug treatment? Can you give me that information? So there are many things that we would need to do if we want to check this medical access, to educate patients and the public about evidence and their role in healthcare decisions, to make time for shared decision-making. There's not a lot of time in a 10-minute consultation. Sometimes in parts of the world that consultation is even shorter. It's much quicker for a doctor and nurse to give a prescription than it is to have that complicated conversation that might give the patient a better sense of what their decision options are. We need to encourage conversations about prescribing, and particularly at the end of life, where a lot of intervention and excess medical care takes place. We need to focus on lifestyle change and healthy aging to try to prevent the need for medical intervention, to campaign for more transparent and independent evidence for healthcare, given the fact that so much of the evidence we use has been done by people with a vested interest in the outcome, and there really isn't that transparency that allows other people to evaluate those data. And we need to call for more independent evaluation and rigorous regulation of drugs and devices. Hippocrates has said, I hope this is a good quote from him, that the secret of change is to focus all your energy not on fighting the old, but on building the new. And healthcare improvement, which this QI Connect initiative is all about, means changing not only how we do things, but what we do. And that was really how I feel this Too Much Medicine agenda does become a quality agenda. We need to change what we do as well as how we do it. It seems to me that too much medicine is squandering resources, it's exhausting healthcare professionals, and it's harming patients. So the big question is, can we, and by we I of course mean you, can you help to shift the effort and money, because money is one of the underlying drivers here, can you shift the effort and money away from pills and tests and onto time with patients for shared decision-making and fully informed personal choices? Can you shift effort and money away from medicalized prevention, by which I mean treatment of individual risk factors, and onto real prevention of the common causes of lifestyle diseases through healthy diet, exercise, sleep, relaxation? Can you shift effort and money away from healthcare, which has become an end in itself, and onto addressing the social determinants of health? So that would be clean air, clean water, housing, education, open spaces, those sorts of things which will be true prevention, and in fact talking here then about health creation. So I think it goes without saying that that's what I want for my dad and my daughter, and I want that for your families too. So I hope that gives you a good account of too much medicine, and I look very much forward to your questions and comments, and please do email me if you'd like to discuss this further, FionaGodlee@bmj.com. Thank you very much.
Thank you very much, Fiona. That was absolutely tremendous. And just to pick up on one of the comments in the chat box, Ian Rudd, who's the Chief Pharmacist in NHS Highland and an SPSP, a Scottish Patient Safety Programme Fellow, says, could we send this WebEx to all members of the Scottish Parliament? So there's some messages there for all people far and wide. It was absolutely great, Fiona. I'm going to come back on some of the comments from the chat box just in a moment. And a big shout out to Simon Packham, who's also asked, he said, all the resources in the chat box and the references that you've made have been a tremendous resource. But let's go from Geneva to Dunblane here in Scotland, and welcome Laura McIver, our Chief Pharmacist at Healthcare Improvement Scotland. Good afternoon, Laura. What did you think of that talk?
Good afternoon, Brian. Thank you, Fiona, so much. That was really interesting, thought-provoking, and very timely with the discussions that we're having in Scotland at the moment around medicines and access to medicines. Will I proceed, Brian, with a question?
Yeah, that would be great, Laura. Thanks. Okay,
so I was really pleased, Fiona, to see the multi-stranded solutions that you set out in your presentation, and in particular, us looking carefully at the role of patients and public. And so I've kind of, on that basis, I've got a two-stranded question for you. First of all, what impact do you believe that patient and public shared decision-making and the patient and public interventions that you set out can make? And also with the emerging pattern around online consultations and prescribing supply, what impact do you think that will make to the current problem?
Thanks very much, Laura. Well, I mean, the patients and public thing I think is absolutely crucial, and I think that there is evidence, and I wish I could quote you a reference, but there is evidence that patients, if given more information, will choose the less intensive option. That's been shown in prostate cancer right back in the 1980s. If you told people about the side effects of transurethral prostate resection, they would often choose to just stick with their nightly incontinence, nightly getting up for a pee, rather than have the operation, and they weren't being given that information. So, and I think the same is true. I mentioned about statins. If you give people the information, they can then, some people would be really happy to take a pill every day for a small few months extra life at the end of their 10 years. But other people would just say, you must be joking, why would I want to do this? And the most recent information we've been having about chemotherapy, real inadequate honesty, or whatever the word is, inadequate sharing of information about the side effects of chemotherapy, the likelihood of dying in hospital as opposed to dying at home, the amount of time you'll spend feeling unwell as a result of this, and you might end up with a few months extra life, but what would that tally up against the amount of time in hospital and time feeling unwell? So it's those kind of really detailed, more shared decision-making that I think we have to move towards. Those conversations do take time. I have a sort of imaginary chart in my head where, or a flow in my head that if we could remove money from the prescribing budget and put that money into time with patients, that would be a very important and good shift. And there might be a benefit in terms of reduced iatrogenic harm. So I think we have to have the patients and the public involved in this conversation, and we have to empower patients to, as I say, ask those questions about what if I did nothing, or what are the alternatives to the treatment that you're offering me, or will this test change things? In what way will having the test change the outcome? Do I want to know something which I can do nothing about? Those sort of questions I think patients should feel free to ask. As for online consultations, I think that you know, we have to move with the times. I think all of us use online banking and online booking of all sorts of things, and we want convenience. And I would be the first to say that these sort of things are going to be the way forward. But I think they'll have to be done on the basis of equality of access to information, and that patients taking part in online consultations will need to be in charge of their own data, be able to you know, decide who's seeing what, and also be in really full command of the medical information that's being used to come to a decision. So it very much changes the nature of the consultation, and I really look forward to seeing how that will evolve.
Thank you very much, Laura. I noticed you get 2 questions in there, quite good of you. So we've got a lot of commentary in the chat box here, Fiona. We've got your friend and mine, Maureen Bisignano, a previous President and CEO at IHI, and Maureen and Anda Ballas, who is the Research Project Director at the University of East Anglia, are both making the point around concentrating on what matters to you. And Carrie Lunan, who's the chair of the Royal College of General Practitioners here in Scotland, making a similar point and encouraging patients and people to have easy access to decision support tools and easy access to the information that they need during the busy consultations. But you mentioned yourself, it's difficult to do that. Any thoughts on how we could change people's contribution in the consultation?
Well, I think it is extremely difficult. There are good, it's very nice to hear from everyone, Maureen, Ballas and Carrie. Thank you for those questions. You know, there are good decision support tools, but they're few and far between. And obviously, as the evidence updates, those decision support tools have got to update as well. So it's a major task. I mean, I think the route I would hope we will take is greater transparency of the research evidence, and I know that not all patients can absorb research evidence, nor would they want to, but actually a surprising number of patients do and will. And you know, we talk about expert patients. Certainly where you've got rarer diseases, patients have to and are really engaging with the research evidence and becoming much more expert in their own condition than the doctors who are helping them. So I think that hierarchy, or that inequality of access to information, is something we've got to address, so that there really can be an equal conversation, the doctor guiding, advising, but the patient making the decision. And part of that is also making sure that the academics who are creating the data are properly independent and have the scrutiny of others looking at their data. So, I mean, I think it's a really difficult one. At every stage in the research, in the turning it into guidelines, into turning those guidelines into little much more bullet pointy conversations, there's lots of information all the way, and there's interpretation and there's influence, and that is a real worry. But I think good doctors will and good nurses will have that conversation, share their uncertainty, try to understand what matters to that patient, as Maureen and others have helped us to understand. And really, for example, understand how much does it matter to you where you're going to die? How much does it matter to you whether you're going to have to take a pill every day and have your blood pressure checked every 6 months and come and have a blood test every year? I mean, do you want that? And if you don't want that, then it's fine, you know. And I think the incentive for the doctor then needs to be, did they have a fully informed conversation with the patient? Not did they prescribe the drug or did they do the referral? it has to be that on which we judge the doctors, that they actually took the time to have that fully informed conversation.
Thanks very much, Fiona, and thanks also to Ian Reeves, who's a geriatrician here in Greater Glasgow and Clyde. He says your talk was inspiring, and he's clapping loudly. We've also got very positive feedback from our friend Steve Gilbert, who's the specialist in anaesthetics and pain medicine, who joins us from Townsville, Australia today. And Steve's given us some great resources in the chat box relevant to what you were saying as well. Now, Richard Norris, who's an honorary fellow at the Academy of Government at the University of Edinburgh, is making a point about harm, and he makes the point that it's easier to blame someone for not doing something than blame someone for doing something that proved unnecessary and diverted resources from somewhere else. Thoughts on that, Fiona?
Well, it's quite interesting that I agree on the face of it. It's easier to blame someone for not doing something, but I think one of the real challenges people face is deprescribing, and worrying that if you take away a drug, someone will suddenly drop down dead with a stroke. And so I think we've got to also provide people with support and encouragement and evidence and guidance on how to take away things, or how to advise patients they might be able to stop things. So I don't know. I think that blame thing can work various ways. I do think worry about litigation, worry about missing something drives a lot of overdiagnosis and overtreatment. That people really fear being pilloried for not taking action. So actually, I would argue the opposite almost of what's been said, if I've got that the right way around. That we need to give people courage that not doing something may be the right thing, and removing something that already is in being prescribed might also be the right thing.
Yeah. Thank you very much, Fiona. Mike McMahon, who's the chair of the New Drugs Committee in the Scottish Medicines Consortium and a physician in NHS Dumfries and Galloway's, he says that he finds that over the years offering options to the patient, and always including the do nothing option, by which he actually means not using medicines, allows him to give the benefits and side effects of that choice, but more importantly allows a patient to see that the doctor considers not giving drugs as an option. Perhaps I have done more time than this, I have more time to do this than a GP. But that business of discussing not doing things, that's relatively new to medicine, right?
Well, I guess it may be. I don't know. Historians may give us a different view on that, but I think there is a human tendency to want to act, and that's why Hippocrates' a requirement that we first do no harm is so important, because the first do no harm is actually, it seems to me, to be a call to think, well, do I need to act? Do I need to do nothing? Can I just wait? Can we just explain to the patient, and between us we can decide that we're going to just monitor this and see what happens. I think the other example is antimicrobial resistance, where it's becoming very clear that overuse of antibiotics is an enormous harm to the world and to individuals as well. And trying to find ways to give people confidence not to use antibiotics is a very interesting example of. And that's something I think people begin to get very clearly, and we maybe need to use that same thinking for other areas of medicine.
Thank you. And back to Carrie Loonan again, the chair of Royal College of General Practitioners in Scotland. So Carrie points to she asks, how do we deal with the increasing frequency of patients opting for non-NHS private screening, e.g. whole body CT scans for their 40th birthday, she says, often done abroad, and then presenting to the NHS for management of what she refers to as incidentalomas. How do we deal with that?
It's such an interesting problem. I'm sure you've all been in receipt of, and I have quite frequently, invitations to go and be screened. And part of me thinks it would be quite a good exercise to go and do this. But of course, how easy would any of us find it to then not act on something that gets discovered. I mean, just for the record, I'm someone who has not had a mammography screening, despite being repeatedly invited to have one from my local NHS, because I'm convinced by the current concern that mammography screening creates overdiagnosis and can do harm. But as for the non-NHS private screening companies, I think the only thing is try to public education, try to help people understand. And it is a difficult concept, this idea that early detection can be harmful. I think doctors find it hard to understand. I think the public perhaps more so. It seems, you know, prevention is better than cure is something we've all understood, but early detection is not prevention. Early detection is early detection, and it detects things that didn't need detecting. Prevention, and that's really what I was trying to say at the end of the talk, prevention is a very different thing. And I think we do need to see transfer of budget to true prevention, which is about making the environment and our food and water and air healthy and encouraging exercise, all those things that will actually lead us to avoid becoming ill in the first place. So I don't have an answer, Kerry, to the problem of non-NHS private screening, except that we have to educate the public. I don't know if Kerry wants to send us her answer.
Carrie, the chat box is yours. But in the meantime, Stephen Fenning, our Clinical Leadership Fellow here at Healthcare Improvement Scotland, and with the Chief Medical Officer, Catherine Calderwood, Stephen has put the link in the chat box to Giles Maskell's blog in the BMJ around incidentalomas. So you might find some background there, folks, as well. Now we're coming near the top of the hour here. I just wanted to shout out to Heather Shearer, who's a clinical teaching fellow at St Andrews University in the postgraduate, the new postgraduate medical school there, the Scott Gem School. And Heather is certainly taken by the information that you're sharing today, Fiona, and making the point that her students might be more receptive to some of the information and the data than previous generations. Do you think this data is getting through to the new generation of medical, pharmacy and other students?
I think so. I hope so. I mean, hard to say, but I do think, especially this idea of lifestyle intervention and prevention is something that we're hearing a great deal from younger medical students wanting to really be active in terms of dietary guidance and understanding the science of lifestyle and dietary change. So those sort of things I think are really coming through. And you know, I think if we can get people early to understand this idea of harm from overtreatment and overdiagnosis, that will be an enormous benefit.
Fiona, that's a great place to leave the talk today. Your mother may not have been keen on doctors, but we're keen on you. So listen, thank you very much for your talk today. Absolutely tremendous. It's given us plenty to think about. Too much medicine winding back the harms of medical excess. And Laura, thank you very much for your questions today as well. Just a big shout out. We've got our final QI Connect of the year. We have e-patient Dave joining us, Dave de Broncat. Dave is a blogger, he's a cancer patient, and he's an activist for patient-driven change in healthcare. And Dave is joining us on the 29th of November. We're really looking forward to his talk. And just before we close, just a big shout out to Scotland's #1 city, that's Glasgow, and the IHI BMJ International Forum for Equality and Safety in Healthcare. And if you want to meet Fiona, you'll meet her there. If you want to meet many of the QI connectors, you'll meet them there as well. So I've put that in your diary for Glasgow 2019. And just to remind you, the QI Connect lineup for 2018, what a wonderful year it's been. Starting off with the Chilean mining disaster and the help that NASA gave to those people in Chile with her first talk from J.D. Polk, and all the way through to Fiona's talk today, and finishing with a patient and a patient experience at the end of the year with Dave next month. So thank you very much, QI Connectors. Looking forward to speaking to you in November. Goodbye. Thank you.